Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled A Balancing Act, Safe Opioid Prescribing, and Opioid Stewardship in the Hospital Setting. We are thrilled to have Dr. Alexandra Varga as our guest speaker today. Dr. Varga earned a Doctor of Pharmacy degree from Notre Dame of Maryland University of Pharmacy in Baltimore. She completed a pharmacy practice residency at the Hospital of the University of Pennsylvania in Philadelphia. After residency, Dr. Varga worked as a unit-based clinical pharmacist at the Hospital of the University of Pennsylvania. Currently, she is a clinical pharmacist at Carewell Health Medical Center in East Orange, New Jersey, and employed by Cardinal Health. In her current role, Dr. Varga is responsible for the implementation and co-leadership of numerous multidisciplinary committees addressing various facets of health system clinical pharmacy, including antimicrobial stewardship and pain management and opioid stewardship. Dr. Varga was a key player in the execution of the obstructive sleep apnea screening program in same-day surgery patients to reduce opioid-related adverse effects. She continues to work with the committee to decrease opioid prescribing in the inpatient and outpatient settings. Before we get started, I would like to share a few quick points. For those who may have technical issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or the chat option. The CE codes will be provided at the end of the program. And with that, I would like to turn the floor over to Dr. Varga.
Thank you, Yumi. Hello, everyone. Just a brief disclosure, my husband does work for Bristol Myers Squibb, but it does not impact the content of this program. So going through some of the learning objectives, today we will describe the current state of the opioid epidemic in the United States, explain the purpose of opioid stewardship in the hospital setting, list some of the core elements of opioid stewardship, discuss strategies for encouraging safe opioid prescribing, and then recognize the role of the pharmacist in the Opioid Stewardship Committee. Just a brief introduction of my health system. We were previously known as East Orange General Hospital. We are under new ownership and a new name with Carewell Health Medical Center. It's a 196-bed community hospital in East Orange, New Jersey. We're the sole independent acute care hospital in Essex County. And due to our new ownership, we are expanding a lot of our services into the behavioral health realm. And we recently opened an inpatient detox unit and residential substance use disorder rehab. So a lot of our focus is moving into behavioral health and substance use disorder. Starting out, not much has to be said about this because I think we're all pretty aware, but the opioid epidemic in the United States is continuing to become a problem. And I think with the pandemic, in the past couple of years, we've seen a lot of issues with mental health, and this has kind of rolled over into our drug overdose deaths. You can see from the chart here, this is nationwide. As the states get into this more darker red color, the count of drug overdose deaths were increasing. And there was a 12% increase, percent change for the United States. So there is a huge impact for patients in drug overdose related deaths. Going through some of the statistics, over 70,000 people died from a drug overdose in 2019. Over 48,000 deaths were attributed to overdoses on synthetic opioids, and 1.6 million people had an opioid use disorder in the past year. So this is a large proportion of patients and a huge problem that we're seeing kind of continuing to evolve, like I said, in light of the pandemic. If you look at some of the potential causes or things that worsen this opioid use or disorder situation. So 90% of general surgery patients are given more opioids than what they need. And 21 to 29% of people are prescribed opioids for chronic pain and they misuse them. So you can see some of the indicators of inappropriate prescribing that are leading to this increased morbidity and mortality for our patients. I don't want to put too much focus on the economic burden, but it is something to keep in mind. The overall estimated cost of the opioid crisis in 2017 was $1.02 trillion. And as we can imagine, now in 2022, there's probably an even more economic burden that can be attributed to opioid epidemic. You can see the majority of the cost was attributable to the value of life lost and the reduced quality of life due to the disorder. And then the next level down would be healthcare costs for the diagnosis and management of opioid use disorder. So there's a really huge impact, not only to the patients, but also to our economic system and the healthcare systems as far as costs related to this issue. This chart here shows the national drug-involved overdose deaths, and I really just wanted to point this out so you can see there's a 38% rise in deaths caused by synthetic opioids from the previous year, and this is from 2019 to 2020, and that line continues to increase through 2022, although we don't have the specific data for this past year. Now that we see the problem, how do we go about combating this issue? This is not a role that can be taken on only by the health systems. We do need a lot of support from the government, and I think there is some place where we can work together to really reach our patients. From the health system, our main focuses should be minimizing this unnecessary prescribing. So as we saw in the statistics, a lot of medications or a lot of opioids are prescribed inappropriately. So this should be a focus of the health system to reduce this unnecessary prescribing. Increasing access to naloxone, this can be providing things to patients at discharge or increasing community access as well. And then appropriate utilization for high-risk patients. So are we looking at patients that might be at high risk for having an adverse event or high risk for having substance use disorder? And are we using our opioids appropriately in those patients? From the government standpoint, we really need them to focus on increased access to treatment, grant funding for research and development, helping to support some of these programs that need to be built for these patients, and increased sharing of data. And this is specifically focused around the PDMP systems so that they are more accessible nationwide. And kind of where we all come together in this is education. From the government and the health system standpoint, there's a lot of stigma related to opioid use disorder and addiction. And I think education needs to be rolled out from all ends as a standard effort to reach patients and let them know and be aware of opioid use disorders. And this kind of all comes together into what we would call opioid stewardship. Now, what is opioid stewardship? So according to AHA, opioid stewardship is intended to be an encompassing term that's not just removing opioid prescribing. It really is looking at a all-encompassed, judicious and appropriate opioid prescribing, appropriate disposal of opioids, diversion prevention, managing the effects of the use of opioids, and this can be identifying and treating opioid use disorder, and also reducing mortality associated with opioid overdoses. So you can see stewardship is a all-encompassing approach to really maintain appropriate use of opioids and also a better quality of life for the patients and preventing any issues that can stem from opioid prescribing. So just to start out with a poll, the first polling question would be, does your organization currently have an opioid stewardship program in place? So A would be yes, we have a very successful program. B, yes, but we would like to improve our efforts. C, no, but we would like to start a program in the near future, or no, not a priority at this time. And feel free to answer the question. All right, so it looks like the majority have a program in place but are trying to improve efforts, and that's good to hear. But there are also a decent amount that are interested in starting a program, and some that have not started a program at all. So I'm hoping that this presentation will help with the build of your program and improvement of your program. So why is opioid stewardship necessary? Why are we focusing on this so much? Basically, if you look at pain management, it's a very complex thing to manage. Opioid stewardship, like I said, is not just removing all opioids and saying no one will get an opioid. The medications have a appropriate role when used in the way that they're supposed to be. So we really need to do our part in improving this crisis. We have to balance our adequate pain management skills while reducing unnecessary opioid prescribing. And as I said, pain management must be individualized to each patient. So one person's pain is not the same as another person's pain, which makes it very complicated for us to treat these patients. If you look from the pain management side, when you're trying to balance this out, you really need to be looking at the appropriate assessment of this pain because it is so individualized to the patient. Each patient needs to have an adequate assessment of what their pain level is and what their goals are for pain management. And then the other things would be to consider non-pharmacologic options. So are we looking at the patient as a whole? Are there different measures that they can take to improve their pain that are not related to medications? And then from the side of reducing opioid prescribing, you should be tracking prescribing very heavily. You should be watching the amounts that are being prescribed and keeping track of who's prescribing more versus less and trying to track those over time. Offering non-opioid alternatives is always a good idea if applicable. And then identifying your high-risk patients. And these are not just high-risk patients for substance use disorder, these are also high-risk patients for adverse events, which we'll talk about a little bit later. And not only is it better for the patient to have a good opioid stewardship program and appropriate opioid prescribing, it is mandatory by a lot of regulatory agencies. So for the next polling question, has your facility received a citation or program recommendation for opioid stewardship? All right, good. It looks like the most of you said no, but there were some that said yes. So the reason why I wanted to bring this question up is because we actually just went through our Joint Commission survey, and it was a very heavy focus for our entire survey. So looking at the different regulatory agencies that focus on opioid stewardship, you can see, as I said here, the Joint Commission has a lot of different measures that need to be followed to follow an appropriate opioid stewardship program. CMS also has a condition of participation specifically for opioid use. And DNV, GL, Healthcare, and IAHO has accreditation requirements also that must be followed by acute care facilities. The CDC offers prescribing guidelines and clinical practice guidelines for opioid prescribing, although those are not something that you could be cited on. As I mentioned, Joint Commission was recently at our hospital earlier this year, and you can see there's multiple standards where opioid stewardship is regulated. We'll go through, I kind of made a chart that we used as a part of our organization to look at some of the key areas that need improvement, but this is where the Joint Commission standards are listed and the specific sections where they mention things related to opioid stewardship. So I broke it down by administrative. So this includes organized leadership team or documentation of an organized leadership team, documentation that your medical staff are involved in protocol development, and are you collecting data on pain management and assessment? When you go into the prescribing, are you looking at offering non-pharmacologic modalities? Are your providers accessing PDMP? Do you have treatment plans that are treating pain? And is the patient involved in those plans, which is one step that a lot of organizations tend to forget? Are you monitoring appropriateness of opioid prescribing? And then from the patient care standpoint, are you providing that equipment for monitoring? Do you have your continuous CO2 monitors when necessary? Are you defining criteria to assess and reassess pain? Are we screening patients for pain in the ED? Are patients being monitored? And are we identifying high-risk patients for adverse events? And then when you move to education, are staff educated on opioid stewardship? Are they aware of the consultation services available, if any? Did we identify our opioid treatment programs that we can refer patients to if needed? And are the patients and families educated at discharge? So this is kind of where our Joint Commission survey centered on when it was related to opioid stewardship. So I thought it was important to bring this in here just for everyone to see. While it is best for patient care, it also is a mandatory step for us in our acute care systems. So now I'm going to move into the core elements of opioid stewardship. And this is basically how you will build your opioid stewardship program for those hospitals that did not have a program or for hospitals that are trying to improve theirs. I used this Stem the Tide document from the American Hospital Association. It's a very comprehensive document, and I recommend anyone who's trying to enhance or build a program to read through it. It has a lot of details on building the program and the steps that you need to take. I'm going to briefly go through each section and kind of talk about some of the things that I've learned in our process of implementation. But first, we can do a quick poll. Does your facility allocate resources? So do you have specific staffing, funding, or education related to opioid stewardship? All right, and it looks like the majority either do not have a program in place or do not have specific funding. I kind of asked that question specifically because as a small institution, we don't have a lot of funding available for a lot of the committees that we do. And most of the leadership team have multifunctional roles, and we're not specifically focused on opioid stewardship. That may be different for larger institutions that do have the funding to put in place. I will say that if you're able to fight for your committee, it is great to have dedicated resources. You're able to do much more. From my standpoint, we still did a lot, but I just think that's something from the role of the pharmacist to fight for their ability to participate in this team and have a lot of resources available for them. So the first step of any initiative would be forming your leadership team. And I started off here with the first person or first people that you should be adding to your team would be executive leadership. Now, this is under the impression that the pharmacist is starting the program. So for me, I was the one who kind of initiated our program and was able to get the team together and start meetings and start setting our goals. But if the team is already in place, it's great for the pharmacist to be a part of it, to be able to offer that clinical knowledge. From the executive leadership standpoint, our CMO is actively involved in our committee, and this really helps us to first gain the interest of other providers. So he actually specifically assigns providers to come to our meetings. And this really helps us to show that support, that it is an organizational priority and that it is something that's important for everyone to attend. The next section, as I said, would be that it's multidisciplinary. So our CMO has specific providers assigned that will come to this. And this is not just pain management providers. This could be anyone really from the ED, the ICU, general medicine. It's really good to have a large variety of different providers because pain is treated in so many different places, not just by the specific pain management committee. So you want to have them all involved, and this will kind of help you to broaden your initiatives and reach more providers and have increased utilization of some of your protocols that you put into place. Project management and IT, they're always helpful to have on board. If you have a project manager to help kind of with some of the more administrative portions of the group, that's always helpful. Information technology is one of the best resources. And nowadays in CPOE systems, all of the alerts and functions that we have within CPOE, some of the time we're not aware of all of the functions. So having an IT support person as a part of the committee is very helpful to help kind of build some of the programs that you are trying to work on. Legal or compliance is also essential. As we mentioned, a lot of the regulatory bodies have significant changes and updates to their mandates. So it's important for us to have legal or compliance there to help us stay up to date on all of those regulatory changes. Something that we're moving forward to in our program would be a patient advocate. I think for something specifically as complicated as pain management and substance use disorder, I think it's very important to have a patient advocate available if you're able to access someone. This will help you to kind of convey some of those critical and unseen perspectives that we miss oftentimes on the healthcare side. So this is how you should form your leadership team. I think obviously a pharmacist is essential as a part of the multidisciplinary committee, but having involvement from all throughout the health system is really important to be able to be a successful committee. The next step as a part of building the program is what we call an environmental scan. This is really just leveraging your existing resources and partners, and this is both internally within your health system and externally. One of the things I like to mention is if you look internally, maybe you're missing something that are missing some services or the ability to offer new services that you weren't aware of. So asking around, seeing the different, and it's strange to say, but we didn't even realize that we had complex pain management providers who were capable of doing rounds on some patients. And we were able to establish that sort of program as a part of our committee. So just asking around, seeing the different the capabilities that the providers have around you is really helpful to help broaden some of your reaches. The one example here would be if you have any waivered providers that are able to prescribe opioid use disorder treatment, gathering that information is very helpful as well. And then once you look internally, you should also look externally. So what services do you have within your community that you can use? And I can say from an external standpoint, because we were a small institution, I went to a webinar from PAMI. It's the Pain Assessment and Management Initiative. This is listed by University of Florida. I highly recommend anyone who's building a program or who needs more information on opioid stewardship to access the University of Florida PAMI website. They have a plethora of information related to patient education and provider education. They have easy downloads that you can send to providers, like little cards for opioid conversions. There's a lot of information there. They have this really interesting non-pharmacologic kit, and it has the different materials that you can include on there. There's a lot of things there from a small community hospital that we really utilize, and they have been a really good resource. And just a small shout out to them. If you contact them from their website, they're able to send you documents and you can change the logo on them for your hospital. But there's specific criteria for that, but speak with them and they're willing to work with you to help you with your program. The other thing that we did as a part of our build was looking into community-based mental health providers. So do we have any pain management or substance use disorders within the community that we can work with? In New Jersey, we work with Rutgers University. They actually have a 24/7 call line. So we were able to provide this printout to all of our patients. If they ever have any issues with substance use disorders, they're able to call this number and they're set up with a technician to speak to about their issues of scheduling an appointment with a mental health provider. So looking into your community and trying to find different resources that are available is really helpful as a part of building your program and helping your patients to get access to what they need. The other steps would be drug disposal locations, community access to naloxone. This is purely just so that you can direct your patients in the right places to go if you don't have those abilities within your hospital. So now that you have your program kind of built, your leadership team there, you've looked at all of the resources that you have available and things you might need, the next step would be measure selection. And this, in my opinion, is one of the most appropriate steps for building any sort of initiative. This is basically how you will assess your current state and how you'll track it moving forward to show improvement. And if you're trying to justify funding or justify hours, FTE hours, you need this sort of tracking to show the benefit of the program. The Stem the Tide document breaks it down into highest impact and least effort, and highest impact, most effort, which is where you should focus most of your efforts. If you can see the box that I highlighted here, are things that Joint Commission do recommend that we are tracking, and these are things that we were asked about on our survey as well. The highest impact, least effort measures here, you can see they're pretty standard. Your average total Morphe mill equivalents per prescription, MMEs per opioid prescription. These are things that typically you can pull from your CPOE system if you're able to pull reports like that or queries like that. These are where you can kind of start. I would recommend starting with the simple list of measures 1, 2, and 3. See if you're able to get that information and then dig into the little bit more deeper, the more effort measures listed here. And you can see for number 4, it's average MME dose administered per patient day, percent of patients receiving opioid only, percent of patients receiving multimodal pain management. So it breaks down a little bit more detail. And these are things that if you're looking at multimodal pain management, if you have a multimodal pain management protocol, you would be looking at the utilization of that, whether it's functional within your health system. So these are more specific to your program after you get the starting point of the total number of MMEs that are being prescribed. While we're talking about MMEs, I did just want to briefly go into Morphe milligram equivalence calculations. So why are we calculating an MME? Basically, the reason why we're looking at MMEs, it's a standardized number to look at all opioid prescribing. If you look at statistics, dosages at or above 50 MMEs per day increases the risk of overdose by at least 2 times than that of less than 20 MMEs per day. So as you increase your MME per day count, you're increasing your risk of overdose or adverse effects. So why are we calculating these total daily doses? It basically will allow you to identify patients who maybe should be monitored more closely because they're at a higher risk of experiencing an adverse effect, or maybe reducing the dose in some patients if that's necessary or possible. Should they receive naloxone prescriptions because they are at a higher MME count, or should other measures be taken to reduce the risk of overdose? So this really gives you a good picture of your opioid prescribing as a whole and whether you're overprescribing for a large number of people. So calculating the MME, obviously it's ideal if this is done for you in some sort of system, if you have that as a part of your CPOE system. If you do have to do it manually, Excel, it can be done in Excel. It's a relatively simple calculation. Basically, you determine the total daily dose of each opioid and then multiply it by the conversion factors. So I included the CDC conversion factors in the chart here. Just something to keep in mind. These are in milligrams per day when you're doing the conversions, except if it is noted somewhere different that the dose is different. You calculate it for each opioid and then add together the MMEs per day for each of them, and that gives you your total MMEs per day. So just a quick poll. Hopefully this won't take too long, but a patient is taking the following medications: a fentanyl patch at 25 micrograms per hour, and oxycodone 10 milligrams every 6 hours scheduled. So what is the total MME per day for this patient? And you can see the chart, hopefully. Okay, great. So just to break that down, the majority of you said 120, which is the correct answer. Just so you can see the math here, for fentanyl, it was one of those special dosage forms or units that is different than milligrams per day. So it's in micrograms per hour. So you do 25 micrograms per hour times the conversion factor of 2.4, and that gives you 60. Oxycodone has 4 dosing intervals, so you do the 10 milligrams times 4, and then multiply it by the conversion factor of 1.5, and that would give you 60. So to get the total MMEs per day, this patient would be on 120. So now that we've gone through some of the measure selection for utilization of opioids, now we're looking into more of the harm reduction. And I think once you get a good idea of how much or how many MMEs you're using per patient, or in a lot of those breakdowns of measures, it's also important to look at how many patients are on an opioid and a benzo co-prescribed. So you can see here, I have the desired quality improvement trend. So as you're tracking this, obviously you would want your co-prescribing of benzos and opioids to decrease over time. For naloxone prescribed for opioid overdose of high-risk patients, this is an increase because you would want to increase your prescribing for naloxone, which you can see down here at the bottom. They also have proportion of hospitalized patients administered naloxone, which you would want to decrease. So you want to have it available for them if they need it, but the utilization to go down. The next harm reduction would be opioid prescriptions greater than 90 MMEs per day. So you really don't want to prescribe greater than 90 MMEs per day unless completely necessary. Something to keep in mind for this, just as a little info or piece of info, is for patients in the ICU, typically these sorts of criteria don't apply. A lot of patients in the ICUs are on benzos and opioids. So if you're writing protocols and things, it's sometimes you might have to exclude the ICU patients or find a different way to monitor them over time. Some of the other measures would be the number of adverse safety events due to opioids, which you would want to decrease. The controlled substance agreements signed and rates of accessing PDMP should increase over time. So these are just some things that you can be tracking as a part of your program. I did just want to do a brief shout out because we had a huge problem with our CPOE system. We had a very difficult time getting Morphe milligram equivalents. Even just to start out of just what is our general use, we weren't able to pull that report without doing a lot of digging within our system. And I know this is a problem, not just for us, but for other institutions as well, if they don't have that reporting data as readily available. We partner with MedAware as a part of our hospital. We basically join them. They work with us for like medication safety monitoring platforms. So they will alert us to any potential medication errors. But in addition to all of those alerts, there's a report that they generate for us, and they're able to pull our Morphe milligram equivalents. This spreadsheet comes across in Excel. We're able to sort it by provider through pivot tables with medication types, the total and average number of MMEs prescribed over any period of time that we select, the MMEs by location, anything over 90, and inpatient versus outpatient prescriptions. So this for us was pivotal in our program. This really helped us to get a good starting point and figure out how to improve over time. So something to consider for your institution. If you're struggling with your CPOE, you might have to reach out to different organizations to see if they have better opioid stewardship modules for you to use. And as I said, the measure selection is really, it will show you how to function in your program and how to improve. So it's very essential. Some other things that we do track is naloxone utilization and order set utilization, which we'll talk about in a little bit. So now that you've built your team, you have your measures in place that you're planning to track over time, you need your policies and procedures. So this is really the heart of your program. This will be kind of where all of your procedures or where all of your initiatives will come out of. I broke this down by acute and chronic pain management, harm reduction, and then supporting patients. So for acute and chronic pain, these are just some of the overall policies you should consider. Both of these should have their own multimodal pain management strategy. For acute pain, you should look into prescribing guidelines for non-operative and post-operative patients. And then for chronic pain management, do you have opioid tapering plans? Do you have patient risk screening, controlled substance agreements, urine drug screening, and PDMP checks? So those are all things you should consider building as a starting point for your program. As far as harm reduction, some of the things to consider would be naloxone administration. So this could be protocols in place for nurses to administer naloxone. For us, we have a policy that makes it mandatory that naloxone is ordered as a part of our order set. So anytime an opioid is ordered, the naloxone PRN order will be there for the nurse. This also could include naloxone at discharge. So if you would like to prescribe naloxone to high-risk patients at discharge from the hospital and also from the ED, that would be where you would put these sorts of protocols in place as a part of your committee. The other thing would be medication reviews for high-risk combinations. So we mentioned tracking opioids and benzos. As a part of our organization, we do have a query for pharmacists to pull all patients on opioids and benzos. If they're on that combination, excluding the ICU patients, the pharmacist will weekly go through them and see if the either medication can be removed or if other recommendations can be made. So having those sorts of policies in place to look at these high-risk combinations is a good starting point. And then supporting patients with opioid use disorder. So are we looking at patients who are on our opioid use disorder treatment in the outpatient setting? Do we have a protocol for them to come into the inpatient setting and to manage their disorder treatment? And are we screening patients for concomitant substance use disorder and behavioral health conditions? Do we do urine drug screens prior to opioid prescribing? Those are things that you would discuss as a committee to determine how you want to handle those situations. And then transitions of care planning. Are we referring patients to pain management clinics? Are they going to substance use disorder management? Do we have the specific policies and protocols in place to make sure that our patients are receiving good transitions of care? So like I said, this is a good starting point for any policies that you should be discussing as a part of your committee. If you're looking at these and you don't have an idea of how this is managed, it would be something you would either take to your committee or take to your P&T to determine the best way to develop a plan. So just briefly, I wanted to go through some of the protocols that we did start as a part of our stewardship program. The essential portion of our stewardship program really was centered on our multimodal pain management protocol. I think this should be the first step in all opioid stewardship programs. You really should have an order set for pain management to help guide providers in using the appropriate medications and the appropriate doses. We call this our ALTO protocol, so it's alternative to opioids. It was actually developed by our chief of anesthesia, who is the champion, pain management champion of our opioid stewardship committee. So we worked with him from a pharmacy standpoint to help with medication dosing and recommendations. And this program or protocol was built for our hospital specifically. So you can see here the providers, if they would like to order pain management, it does give them a breakdown of specific high risk categories. And these are patients who may or may not be at high risk for opioid related adverse events. So the provider then would select which category their patient falls in, and then the appropriate medications would show up based off of their selection. Just an example here, if you look at not frail versus frail elderly, some of the differences are basically related to some of the dosing for frail elderly who may have renal impairment. And also you can see here, there are lower dose options for oxycodone, hydromorphone, or morphine. What we noticed is that it's standard for the provider to just go for that oxycodone 5 milligram tab as a starting dose for all patients, just because that's what they're comfortable with. They know that it comes in a tablet, they're able to start there. If you give them the option to order the suspension, they're able to get lower doses for your elderly patients that may not need that full 5 milligrams. So having that option kind of in front of their face and forcing them to go that route, it does help them to pick lower doses for elderly patients. So we've noticed that that was a huge impact for our initial starting doses of MMEs. Something that the protocol also offers is non-opioid options. So we break it down by musculoskeletal, neuropathic, and we have topical agents as well. This gives the provider the background to pick specific medications for specific types of pain. And again, having it in front of them, it really streamlines their utilization and helps them to go down the list and pick which medications are appropriate. The other thing at the very bottom of our protocol is non-pharmacologic options. So these are things that the nurses are able to order, and our nurses have been educated on non-pharmacologic options, things like holistic care, teaching, psychiatry consults, ice packs, physical therapy, things like that that are available to the patient for non-pharmacologic options. The next protocol that we have in place is our obstructive sleep apnea screening. This was something that was brought about by our chief of anesthesia. He was very concerned that patients are coming in for specifically same-day surgery procedures and then going home on opioids and then experiencing adverse events at home because we didn't appropriately screen them and their risk criteria for opioid-related adverse events. So one thing we focused on, we started in same-day surgery. We were looking at patients with potential obstructive sleep apnea. The reason was these patients are at a high risk of experiencing respiratory depression from opioids. So screening for OSA helps us to identify these patients and again, making sure that they're going home on appropriate and safe doses of opioids and with appropriate education. So like I said, same-day surgery was where we started. For pre-procedure screening, we have the nurse do a modified stop bang assessment. This is purely just a quick questionnaire that's built into our CPOE system. It asks questions like, do you snore? How often do you wake up at night? And if the patient scores at high risk for obstructive sleep apnea using that assessment, they do consult with anesthesia. Anesthesia will then determine if the patient is safe to go through with the procedure and the anesthesia. And they also will do appropriate intra and post-operative management, which would be increasing monitoring with continuous CO2s and OSA pain management protocol utilization. And then most importantly, we will refer our patients to a sleep study to diagnose their OSA and also give them education on the risks of opioid-related adverse events. So this is something that we were focusing on in same-day surgery, and we are rolling it out to our emergency room. So then we'll be able to screen patients that are being admitted and use the appropriate pain management in the inpatient setting. So again, now that we've built kind of the heart of our program, you have your policies in place, you've worked on specific protocols, you've pinpointed where your pain points are, and no pun intended, you figured out where you need to make the most impact. Now you need to work on patient education. As with any program, patient education is essential because the patient is the end user and they're the ones that should understand what they're taking and what their risks are. I start out with patient education in pain management. I think from a pain management standpoint, as we said, pain is very specific to each person. So you really need to set those pain expectations with the patient. If a patient is going into surgery, say an orthopedic surgery, they cannot expect to wake up from that surgery with zero pain. So letting them know ahead of time that there might be some discomfort, that they have specific options available to them, that might help them to be less likely to request more opioids after the surgery. Looking at some of the risks of opioids, I think most of the providers and pharmacists they're aware of the risks, and we just assume that the patients are. I would say not a lot of patients know about all of the potential side effects that can come from opioids. So going through that with them, helping them to understand our concerns on the use of opioids is very important to help them get a better understanding. And then non-pharmacologic and non-opioid treatment options. Something as simple for specific types of pain is just taking Tylenol, and taking it around the clock can really make an impact on pain management, something that's less harmful than opioids and makes an impact on their pain improvement. And then non-pharmacologic measures, are you teaching them about all of the different measures that they can do to kind of help calm them and help them to manage their pain in a non-pharmacologic way? And then for harm prevention, every patient should be taught about storing medications appropriately. I know I have kids and I constantly have to talk with my parents about storing medications out of their way that the kids can't reach them. So talking with patients about putting specific things like opioids out of sight, especially if they have visitors or children running around, putting them in cabinets, keeping them stored appropriately is very important. Going through the specific administration instructions. A lot of times a patient sees PRN and they think that they're supposed to take it every 6 hours, even if they don't have pain, because they're scared to have pain. Just having that discussion with the patient to help them understand how the opioid works and how to take it appropriately is very important. And then naloxone administration, if necessary, is always good to go through to make sure that they're comfortable with administering it and that their family is comfortable with administering it. And then for opioid use disorder, do you have a referral process? So this was part of the policies that we were talking about. Is there a place that the patient can be directed to go if they feel that they're having an opioid use disorder issue, or if they feel like they're starting to become addicted? Having that discussion with the patient, whether they are high risk or not, is always important, just to have it out there, have it available for them in case they or someone they know needs help. And any protocol education for buprenorphine initiation is also, if applicable, something that you should work through. So now that we've talked about the program, I know I mentioned a lot about the multidisciplinary committees, and I mentioned that pharmacists have a huge role. I know from my committee, as I said, I was kind of the one who initiated it, and I'm the one who kind of pushes forward all of our programs. That's not the same in every institution. So it's important to figure out what your role can be. And this study was done, it was a national survey conducted by ASHP. They basically looked at pharmacy practices in the hospital setting. One of the sections that they reviewed was the pharmacy-led opioid stewardship strategies and where pharmacists were making an impact. You can see from the pharmacist roles on opioid stewardship programs, the majority of it is in diversion prevention and detection. And then the next step would be clinical utilization review. So these would be some of your things like looking at home discharge opioid prescription medications, as you can see in the chart, looking at non-pharmacologic and non-opioid pain management treatment options. And then, like I mentioned, looking at patients who are co-prescribed benzos and opioids. These are all things that the pharmacist can make a really good impact with our specialty. The other things on here that I thought were interesting would be restricting specific opioids or doses above a threshold of MME. And I know that's a controversial topic, but if that's something in your organization that you have the ability to do, having even just a pharmacist review for patients over a certain MME is also helpful to review the chart to make sure that the patient's taking the medications appropriately, and just having the pharmacist presence there to look over the medications that are available. So you can see, I think pharmacist involvement is different in every single institution. So like I said, you just have to find your place and figure out where you can offer the most help and the most improvement for your patients. I think that was all that I had. So I'm open for any questions or any comments. And as I mentioned, like my email's there. I'm open for any questions outside of the chat or outside of the webinar as well. If you need any information, I'm happy to share with anything that I have.
Thank you, Dr. Varga, for the presentation. I'm going to take a look into the chat box and the question box to see if there are any questions. Again, if any of you in the audience would like to ask a question, you can enter it right in the question and answer box. There are two questions in there. The first one is, what specialists should be recruited to involve in an opioid stewardship program?
So I think that depends on your institution. So as I mentioned, we have our chief of anesthesia. He is very big on pain management. So I think for him, or for us, that was key. You have to have someone who's passionate about pain management. And like I said, he created our protocol for us. So I think you need to find that person who's able and willing to participate. From a different side, if you don't know that clear provider who has that sort of passion, looking into any pain management, any even just general medicine, look into your PACU. Do you have providers that are often prescribing there? Any surgeons that are interested? So it's kind of just seeing where the majority of your opioid prescribing is, and then pulling those providers in to see if they have some sort of role or would like some sort of role in your program. And that, again, it varies per institution. If you have a pain management program, I would start there because obviously they should have passion in pain management. But stepping outside of that, it might help to just do that query, look at where all of your opioid prescribing is done. And the most, if you have a post-surgical unit, that probably would get a lot of interest from the provider standpoint.
Great. There was another question in there asking, what was the center in Florida that has this free resource? So that question was asked kind of in the during the middle of the presentation.
Got it. Yeah, so I have it here in case you need it. It's reference number 11, Pain Assessment and Management Initiative. It's called PAMI, and you can use the link there. And their website has a lot of information. Just feel free to click through.
Great. There are also, I'm just going to skip over that for a second. So how difficult was it to find those key leaders at your institution?
It is hard sometimes to get involvement, and I say that as a growing program, we have varying and waning interests. So in the very beginning, it was very big; a lot of people were joining, and then over time, the meetings kind of started to dwindle. I think it's difficult to get interest, but what I can say is, as you start to make changes, as you start to implement programs, the providers notice that things are changing. So there was at one point we were thinking of removing all of our opioids from prescribing and forcing all prescribing to go through our protocol. When you make changes like that, the providers then get involved. It's kind of like voting in the government. They see that things are changing, and then you kind of tell them like, okay, here's our committee, please join it. And then they come in. So I know it's hard to get provider interest a lot of times, but I think you just have to continue to reach out to them, find the one provider that you can really rely on, and then the rest will kind of come around as they start to see and want changes.
Great. Next question. What were the challenges you encountered when you were building a new opioid stewardship program, and how did you overcome them?
Our biggest challenges were the lack of funding and resources. I also run other programs within our hospital, so trying to balance all of the committees being started from scratch was very difficult. And I think from a pharmacist standpoint, we have many other roles. So unless you're dedicated specifically to opioid stewardship, it's hard to really give the amount of time that it needs. Our second challenge was the data collection. Data collection for opioids was very difficult. Getting everything into a spreadsheet, calculating the MMEs was not a simple process. So That's why I think MetaWare really turned it around, because I struggled with getting that data and having someone do it for me was very essential. And I think even still to this day, just justifying the program, being able to show change, because it's not something that your opioid prescribing will just stop and you can say, wow, look, my program did something big. So it's a slow over time change that you have to continue to track to be able to show the benefits of the program. So those are some of the things we're struggling with and we continue to struggle with.
Great. So this one is about outpatient pharmacy. So any insight on how outpatient pharmacies can ensure the new New York State regulation of requiring an opioid antagonist prescription for patients being prescribed greater than 90 MMEs?
That's an interesting question. I don't know specifically from the outpatient setting how they would ensure that. Um, I guess I would have to look into that a little bit more of their ability to, like, if there is a naloxone protocol, can they prescribe naloxone? Are there things that they can do from the outpatient side? But that's a great question. I'm not sure. I'd be happy to look into it and get back to the group.
So someone also asked, how do you monitor opioid prescribing per prescriber? Do you
So
do
this,
average MME per day?
yes, and just another, while I have a couple minutes, some of the problems that we came up with were PRN orders. So thankfully for our institution, our prescribers were doing a lot of PRN orders. So how do you document that as an MME? Because it's really what the patient takes if they choose to take it. So some of the things that we did per provider was looking at all of their orders, again, calculating the MMEs. If anything was PRN, basically we would use as if the patient took the full PRN interval, every dose that was available, and use that to calculate their MME, which the providers were not happy about, but it was the best way to standardize the amount of prescribing that they were doing. Because technically, if they prescribed the PRN, they gave the patient the ability to take all of those doses. So we calculated that as what was prescribed. But it's really up to your system. So if you're able to pull all opioid administrations, then obviously you wouldn't have the ability to pull all of the PRNs. But if you can pull every order that was done and then sort it by what was an active order and then sort it by provider, it's again completely dependent on your system, what you're using for CPOE.
Great. So a lot of good questions in the question box. Next one, how do you show the impact in monetary aspect when you are trying to justify to start the program like that?
That is a great question. Honestly, we didn't have to prove it too much just because Joint Commission mandates it and we have to have these programs in place. So we didn't have to say, this is why we should have a program. But if you are trying to justify for funding support, I'm sure there's some information you can pull on the cost of opioid overdose or opioid related events, adverse events. A lot of that data is available. I'm not sure if there's a specific length of stay increase, but those are the places I would start to see if you can pull data on the cost of an opioid overdose and a naloxone administration, things like that. That would be where you'd see your biggest impact because the amount of opioid utilization with your program should go down, therefore the adverse events would decrease.
Right. And another question, is the rise in synthetic opioids due to the pandemic?
It's hard to tell if it's specifically due to the pandemic. The rise has been going up since 2000, I think 18. So I don't say it's specifically due to the pandemic. I don't think it's helped to have the pandemic in place. But I think the synthetic opioid, it's mostly fentanyl. I think that's more from street sales that we're starting to see an increase of and the ability to manufacture it. So the pandemic didn't help with the mental health standpoint of it, but I think there also is another issue that we have to address outside of the health system related to fentanyl overdose.
Thank you. And I actually also have a question myself. I wanted to ask how, you make all these like great protocols, right? Like how do you get your prescribers on board in utilizing these different pain protocols? And do you do some type of like monitoring afterwards to see if they've been compliant?
Yes. So this is actually going back to the question of our biggest struggle. So we made this beautiful pain management protocol. And because the opioids were like a provider would just type in oxycodone versus searching for our protocol, they didn't use the protocol anymore. So that was a huge issue because we had everything in front of them clear for them to use, and they didn't use it. And I think for the first year of our program, it was mind blowing of just how do you get them to search for pain management protocol and utilize the protocol that they're supposed to be doing. So we went, this goes back to having support from your executive leadership on your committee. So this helps you to kind of enforce some of the protocols and policies that you have in place. We were doing CMEs for the providers. We were helping them to be aware of the availability of the protocols that we have in place, and just kind of constantly doing that on the ground effort of just letting people know. We made posters, we put them around the unit. What really helped was when we were able to start tracking your MMEs by provider, having that readily available to the providers to see their use. And I don't blame any of them, but I think that if you don't look at how you're using things over the tons of patients that you see, you don't really realize the problem that you have. So I think that doing all of those steps, constant education, showing them the problems, really help them to start looking for the different protocols that we have and using the things that we have in place for them.
Great. And just a reminder for the audience, if you have any questions, you can enter it into the question and answer box. Let's see. In the meantime, I don't see any more questions there.